I'm going to talk about feline coronavirus and FIP today, and specifically I'm going to review some of the things we want to make sure everybody knows and kind of understands where we're coming from in terms of our traditional understanding. And then we're also going to talk a little bit about what's on the horizon. And I actually have Dr. Gary Whittaker in the audience today as well. Many of you are familiar with the Whittaker Lab, so I'm hoping we'll have some time where we can actually entertain some more laboratory and kind of diagnostic questions that you may have. But FIP and corona in shelters is a particular problem because we actually have one of the highest risk populations. Whether it's in a traditional brick and mortar shelter, whether it's a foster system, whether it's a rescue-based system. And so honestly, this happens where we live. And so there's many things that we need to do, but in terms of our management, in terms of our strategic planning around these populations to really try and both prevent the disease and then control it when we see it. So let's make sure we're all on the same page. We'll do a little bit of review. So feline coronavirus. It's a pretty virus, I think. I had the honor of working on the chapter in the new Infectious Disease for Shelter Medicine book, and Dr. Lori Peek from Maddie's Fund actually illustrated this virus for me. So I have an amazing drawing that she did of it. It's an intestinal virus, as you know. Generally, coronavirus, feline coronavirus, causes a self-limiting diarrhea, and it's ubiquitous in our cat populations. And so we're never going to kind of eliminate that from our cat problems, but it on its own is not a big deal. It's a large positive stranded RNA genome, and why do we care about that? Well, we care because it's a large virus, so it's actually hard to study, and it's hard to map even with our newer technologies. It's hard to sequence because it's so big. Because it's so big, there's more opportunity for mutations in the virus, and so that's why we see some of the challenges in not only diagnosing it, but kind of wrapping our hands around treatments or vaccines. And because it's so big, it is highly susceptible to mutation. And so it's a mutable virus that's changing all the time, changing between cats. And so I feel like as a profession, as a veterinary profession, we're chasing it as quickly as we can, but it's a really hard thing to wrestle with. So it has a tropism for epithelial cells, so it makes sense that it would impact our GI system in particular. But certainly we can see coronavirus in other areas. And so that may be something, and we'll kind of talk about it a little bit later, that we investigate as we go along. Traditionally, we talk about two serotypes of coronavirus, so two different serotypes. One is a type 1, and that has predominated in Europe and in America. And then a type 2, which is actually a recombination of the feline virus with the canine coronavirus, as we've understood it. And that is primarily in Asia. And this kind of typing system will come up a little bit later as we talk about some of the more recent outbreaks that have occurred. But we talk about two serotypes of coronavirus, and both of those can result in FIP when the right mutations occur. Oh, that's Dr. Lori Peek's drawing. I'm glad I actually included it. I wasn't sure I did, which I think is particularly beautiful. She's a veterinarian, but she's also a medical illustrator. And so it was nice of her to do that for me. So I'm going to talk a little bit about nomenclature. And again, we kind of moved into this nomenclature. We may be advancing out of it. But generally, we're going to use FCoV for feline coronavirus, that common ubiquitous virus that we see that causes self-limiting diarrhea. I'm going to use FECV to talk about the enteric biotype, the virus when it enters intestinal epithelial cells and actually impacts and causes some disease there. And then I'm going to use FIPV to represent that mutation of the virus that has a tropism for macrophages and ultimately results in the FIP syndrome, which is the disease syndrome. So just for clarity, that's how I'm going to use the nomenclature for this lecture. There's still some questions about how much these are really separate, depending on the sequencing and on a molecular level, but this is going to serve for our understanding of what we're talking about today. So transmission of coronavirus, absolutely widespread. In a densely housed population, which is our nice terminology for overcrowded shelters, hoarding facilities, and kitten season, and it is up to 90% of cats are seropositive. So reminding you, seropositive means they have had antibody responses to the coronavirus. They have been exposed. That doesn't mean they have active disease necessarily, but they've been exposed. Up to 90% in our densely housed populations. There was a shelter study that investigated cats and kittens at the point of entry to a shelter, and then 1 week later, a third of the cats were seropositive when they came in. Or I'm sorry, this is a shedding study. were shedding coronavirus at entry, and 1 week later, greater than 60% of them were shedding. So we know that exposure happens in our shelters, and we know that they will then shed, which means they can go on to essentially pass this disease through our population, depending on our housing and husbandry practices. It can be transmitted in several ways. Oronasal is what we think of most commonly, fecal-oral, and then transplacental, all possible. So obviously cat-to-cat contact is an issue, but litter boxes are a big issue, especially because that's what they're shedding into. And the shedding can go on for months to years. So this is not going to be something that we eradicate. This is going to be something that we need to talk about risk mitigation, like most of our diseases that we talk about in veterinary medicine and most of our diseases that we talk about in shelters. And so we're going to be mitigating this risk from the moment a cat walks into our organization. Long-term studies have demonstrated that there are cycles of shedding, recovery, and reinfection. So a cat can get coronavirus, shed it, stop shedding. They can actually get reinfected, often with a different coronavirus, shed, and all of that. Seroconversion, just because you have a serology, you're positive on serology for coronavirus, does not protect you against getting coronavirus again. And some of that may speak to the fact that it's a highly mutable virus and coronaviruses change. And so therefore, just because you had one doesn't mean you're protected against a different mutation. And so there are cycles of this constantly. Now, when we talk about enteritis, actual clinical disease that can result from the coronavirus, we're talking about this FECV, as I'm going to call it today. And so most of those cats are subclinical, especially in a shelter where we expect some diarrhea, loose stool from a lot of our kittens or our young cats, or even our adults who come in and are under stress in that environment. So you may see some mild diarrhea. It does replicate in the oropharynx first, so that's an interesting detail that I want you to remember. And then it also replicates in enterocytes. And then they shed within 2 to 7 days. And again, this can be intermittent or cyclical. Kittens that are chronically infected, because there are some kittens that will become chronically infected and just constantly shed and not necessarily respond well, they are more likely to be those kittens that have persistent diarrhea, that they're tiny, they're stunted, they've got ill thrift, and that makes sense. Like at this point of growth, they need their nutrition, and essentially this food is passing through, and some of that diarrhea, they don't do well. And so there is evidence that some of those kittens that just continue to have diarrhea and are too small may in fact have coronavirus enteritis. Now again, I remind you, if you are just testing serology, you're going to see high levels across the board anyway. And if you're just testing shedding, a lot of them will be shedding. So just finding coronavirus doesn't mean that that's the cause of this, but there is a correlation between those kittens that are ill doers and FECV. So how do we get from coronavirus to the actual FIPV, from what is a ubiquitous, relatively harmless virus to this FIP virus? And this is kind of the big question that we've been looking at for a long time. And the most common theory is the internal mutation theory, that essentially that FECV or that FCoV mutates, which then allows it to enter macrophages. And once it enters macrophages, it then can replicate in those macrophages and move into tissues. And so tissues essentially become infected. And it spreads from macrophage to macrophage. And so you've seen a mutation in that virus in that cat, which then results in FIP in the cat. And so that's why it's called internal mutation, essentially internal to that situation. And so if you're working with that sense of how this happens, that you go from a ubiquitous common virus to that cat getting FIP, essentially that means it's not transmissible to other cats, because that FIPV has changed in the cat and is not necessarily spread to other cats. And a lot of research has gone into looking at the mutation sites, which ones are actually implicated in this mutation. And there's various studies that look at the S gene, S1, S2, or ORF, and even some other sites have come up since then. And so chasing this mutation site is a big point of research. And again, I remind you, it's a huge genome, and so there's lots of places to look, and that's why it's taking as long as it does, because this is really hard work to do. FIPVs can arise from both type 1 and type 2 serotypes. And so some cats actually have both. You can have cats, and this was done on post-mortem studies. Some of the cats will FIPV will have both type 1 and type 2. What's not clear is whether the mutations in type 1 are the same as in type 2, or if these are different mutations depending on the type of virus. And it is important to recognize that cats do shed FIPV in their feces, as well as in saliva and urine. These are really low levels of the FIPV virus, and I'm going to talk about diagnostic testing in a little bit. They do shed it, but it's usually not in high enough rates to go testing with our traditional testing methods. So this too is a point of research to figure out how can we change our testing, or what tests can we develop that can be done on poop rather than on necropsy, which is where we tend to diagnose FIP definitively in a lot of cases. So traditional thinking was that this conversion from FIP, from coronavirus to FIPV, was somewhat spontaneous and unique to individual cats, and that it's not contagious between cats. And it was also thought to be uniformly fatal, that cats could not survive FIP, and truly the vast majority cannot. There have been some laboratory studies that have challenged cats with FIP and had them develop disease and actually go on to live for a fairly long amount of time. But those have been very small numbers in completely controlled laboratory settings. Generally speaking, we think it's uniformly fatal. This has been supported by sequencing studies and longitudinal studies, as well as the rarity of outbreak. So we don't see a lot of outbreaks of FIPV. We have seen some. And so that's kind of the big question, are there some mutations of this virus that can be transmitted horizontally? Because that's kind of our biggest fear, right? The comfort that we've taken is that when we do have one of those cats that develops FIP in our shelter, that it's like, okay, this cat unfortunately had the genetics or cofactors that allowed for this mutation to occur, but at least it's not contagious to other cats. It's the comfort we've taken. There's potential that it may be contagious depending on the mutations that occurred or the type that we have. And some of the evidence that supports this was an outbreak in Asia in 2011. This was in a densely housed population, essentially a shelter. It was a long-term shelter, a long-term holding shelter. So I would almost describe it as somewhere in the shelter sanctuary spectrum, because the cats had been there for a long time. Litters of kittens were introduced, and then they saw progressive illness between August and September. 13 out of 46 cats in the shelter died from FIP between September of 2011 and April of 2012. 33 of those cats remained healthy, but 26 of them were positive for FOCV, so not the mutation that they saw in the sick cats. And when they amplified the virus from the sick cats, it was a type 2 virus, and it was unique. It was the same mutation in all of those cats based on the sequencing that they could do. And so this was concerning because it was kind of to my knowledge, kind of the first one that was truly captured and published, that this might have been a horizontal transmission of FIPV. And is this something that we either have failed to recognize or failed to document? And what allowed us to kind of know that this might be different was that we could actually amplify and sequence this to see that it was a unique mutation that they shared. And so that kind of opened that door into the conversation. And so this does say, wow, is this a bigger risk in our shelters than I knew before? And I think the answer could be maybe, but I think there's a lot of other things we have to talk about in addition to, do I have a bad coronavirus or a bad FIP in my shelter? Because that's generally when people contact us, is when they think they have a zebra, like this is really, really bad. And so before I go down that pathway of you have something really, really bad and it's going to be a major outbreak in your shelter, if you've ever called me, you know I have about 100 other questions first. And a lot of those are going to step back into what is your management, what is your population, what are you doing? Let's talk about those things first. Because it's always, always, always going to be a game of risk mitigation. And I will come back to this idea of horizontal transmission towards the end. So, reminding you about some of those management things. Do remember that overall FIP is a disease of young cats, and that probably represents your experience. So we look at kittens and young cats. That somewhat makes sense. They've got compromised immune systems. They tend to shed higher levels of virus. They tend to be the populations that are in shelters, that are in foster care, and actually are in larger populations. Males are more common than females. Don't exactly know why. If anybody has an idea, I'd love to hear it. Younger cats are more likely to shed, like I said, diarrhea, compromised immunity, and concurrent infections. And so there's all sorts of things that we think about in managing those younger cat populations, which can help us manage both coronavirus and the chances of developing the more pathological forms. In densely housed populations and catteries, the incidence of FIP is usually 5 to 10%. That's really high, and that comes out of some older literature looking at kind of overcrowded cattery situations. In a research cattery that was much more controlled, and essentially research catteries have more restrictions on them in terms of the quality of housing that they provide than perchance a private cattery with an individual acting alone sort of person, as we know. And so in a research cattery, it was actually very low. So when they kind of exposed and said how much FIP are we going to get out of these coronavirus exposed cats, it was less than 1% under research conditions. And so generally what we've come to in shelters is that a rate of 1% we live with. If you have a rate of higher than 1% in your cat population, we start to worry that there's something going on. And that something may be management practices and that sort of thing, or that something may be an outbreak that we need to investigate. But up to 1%, we kind of say, okay, this is to be expected in a shelter population. Fewer than 3% of coronavirus seropositive cats will develop FIP. So I want you to remember that, because I think one of the biggest mistakes we make as veterinarians is when we overdiagnose with serology. Again, reminding you that a lot of cats are seropositive and not sick and not FIP. So knowing what to do with a seropositive cat is really important. Knowing not to diagnose it with FIP, basically. And so fewer than 3% of them will actually develop FIP. Risk factors, I've already kind of explained that, hoarding, cattery, shelters, and then stress. So I don't think we've been really good at documenting the stressful risk factors that play a role, but as I talk to shelters when they're having an increase in FIP cases or they're worried about the percentages that they're seeing, I often ask them questions like, what did this cat just go through? Like, can we trace this back at all? And it appears like surgery is certainly one of those stressful points where they'll have surgery and then you'll kind of see 1 to 2 weeks later is when we see the kitten starting to show signs. Vaccinations are certainly an immune stress. New home environments, that's the worst because you just sent home this cute fuzzy cat that you worked so hard to get there. You had it in foster for weeks and people love it and it was their favorite, and then it gets the perfect home with the perfect 2.5 kids, in the perfect family, and it's 3 weeks after it goes home and now it's starting to show signs of illness. And we all hate that. But certainly these changes, we think, do contribute to their development of clinical signs. And that seems to make sense in terms of kind of physiological support for developing disease. And then we do know that purebred cats are at higher risk. And again, this is a disease that we essentially created in our catteries and our shelters. I'll talk a little bit about that. But purebred cats, because they have the same genetics, may also have the same genetic predisposition to developing FIP. And so we don't truly understand it, but we do know that it's a risk factor, and that genetic predisposition speaks to it. Reminder about clinical signs, the eyes are it for me. Like the first thing, I've got a kitten with waxing waning fever, I go looking at the eyes because uveitis is one of the earlier signs. It can be subtle very early. But I always do an ophthalmic exam and go looking for something that doesn't look normal. I am not an ophthalmologist. So what I'm basically looking at is, does it look weird? The other thing is lethargy and anorexia, those kittens don't tend to be lethargic and they don't tend to stop eating. So you got some reports of these waxing waning, not eating very well, maybe recurrent fevers or a cyclical fever if you're tracking that. Icterus is like the big one that kind of nails it, that you're really having some problems, but that uveitis is really important to me because a lot of times what I will see is just that very early iritis and then a little bit of clouding in the anterior chamber, and I look at that kitten and then I start looking to see, can I find fluid somewhere? Can I find something else that's going to help me with my diagnosis? Certainly there are also the neurologic signs. That tends to be something that I see more in adult cats. As more of a later extension, and I'm going to talk a little bit about the clinical forms in a moment. But for my kittens, which is the bulk of the population where I diagnose FIP, and most of you that I talk to, it's that uveitis, waxing waning, fevers, just not doing well, and then down the line, boom, you usually have a diagnosis. And sometimes you have it faster rather than slower. In veterinary school, we kind of learn this division, like there's the wet form with the fluids and the effusion, and the dry form that gets granulomas that shows up later. We do know that it's not really that simple. It's not two ends, it's a spectrum. And so cats have somewhere on the spectrum between wet to dry. You'll see a lot more with early effusions of the younger ones because of the way it's responding, but quite a few of them will have dry form, and it's somewhere in between you'll have a combination of wet and dry. The pathogenesis really depends, and the reason why you have that spectrum is because it depends on how the cat is responding to the virus. So it depends on whether they're responding on a cell-mediated level or a humoral level. And so if they eliminate the virus, or they're trying to eliminate the virus, you often see an active T cell response, and we do think that some cats get exposed or have a mutation and may eliminate it. So they get exposed, they actually have mutated, but the body essentially cleans that mutation up. We do believe that's a small subset of cats. Then we have the ones that essentially activate complement, and so what you see in those guys is that pyogranulomatous vasculitis. So you will see, if you are actually looking at them on necropsy or on intestinal biopsy, if you've gone chasing biopsies, you'll actually see those little granulomas all along the vessels. And that's your complement activation. Versus what then becomes antibody-antigen complexes, and that's where you really start to clog up the various vessels and fluid moves out into third spaces. And so now you have wide-scale effusion. And again, on a shelter basis, that's where I feel like we diagnose it most often, is when we actually start to see those effusions. And then if you have a cell-mediated response and your T cell response becomes depleted, you get granulomas without effusion. And so how the cat is responding on this spectrum of response is thought, and this is somewhat of a theory, but is thought to then impact where they fall on that spectrum of clinical signs. And so again, the eyes have it for me. Clinical history, signalment, and the eyes. And so I'm always chasing that to look there first, because I feel like that's where we can really identify it, at least on a clinical basis. And again, that's what we're working with most of the time as our forefront. Reminding you that coronavirus antibody, I kind of already went over this, only represents corona exposure, not FIPV. And some cats with FIP will actually end up testing negative on serology towards the end of their disease because they essentially have exhausted their antibody response. And so you may get a negative response when they're essentially at the terminal end. Seropositivity is not going to say, if you're positive for coronavirus, that doesn't mean it's the cause of your diarrhea. So that's fairly obvious from what I said earlier. And seropositivity does not reflect shedding status. So I cannot use serology to predict who's shedding coronavirus in my shelter. That would not be a correct use of that test. And a test that Dr. Addie did, only 33% of positive cats on serology were actively shedding virus at that time. So then what do we use? So you have this case, it's waxing and waning, you don't have a ton of fluid in the abdomen yet, because really that for me is where I feel like I can get my best diagnosis. What do you use? A CBC can be helpful. So they can have an anemia. Now kittens can have an anemia anyway. So clinically speaking, that can be challenging. You can see a lymphopenia. You can see a neutrophilic leukocytosis, and what you're tending to see is kind of a stress leukogram. On chemistry, over half the cats with FIP have hyperglobulinemia. So your globulin can be helpful. Again, if it's not elevated, that's not a slam dunk, but if it's elevated, that's also not a slam dunk, but it makes you highly suspicious. Elevated liver enzymes and bilirubin do come along. The classic thought was that was coming from injury to the liver based on the disease, but there's also some thoughts that that's actually coming secondary to some hemolysis that may be happening with the clinical disease. And so whether it's coming from either of those, you will sometimes see elevated liver enzymes, and we're not sure we exactly understand where that's coming from. And then azotemia also plays a role. If you have effusion, that's probably the closest I feel like you can get, because that you can use it for some diagnostic testing, other than necropsy, which is kind of the gold standard. So if you have an effusion, straw-colored, total protein greater than 3.5 is kind of our standard. On a refractometer is perfectly acceptable to drop the fluid on your refractometer you use for urine. I do think it's important to kind of to look at it under a microscope too and spin it down, because what's different about this effusion from effusions due to other diseases is that this will have a very low cell count. So it's an elevated protein count, but a low cell count. So if I've got a peritonitis or something that can also look like this, I'm going to have a lot of white cells in that fluid when I look at it under a microscope. If I have FIP, I have almost no cells. There'll be some scattered lymphocytes, maybe a few macrophages, but it's a completely non-septic quiet sediment. And so it is important to look at that as well. Looking at albumin globulin on the effusion can be very close to getting diagnosis. So you can take your albumin globulin ratio in less than 0.9 is fairly sensitive and specific for FIP. That's on the effusion, not on blood. A lot of times that ratio gets applied to blood and it can help you, but it's not as diagnostic as if you do this on the effusion and you get that ratio. Major differential diagnoses, lymphoma. Again, let's look at our signalment. So it's a 12-week-old kitten, probably not lymphoma. Heart failure, maybe, but generally you're going to have something else on physical exam that helps with that. Liver disease, and then bacterial peritonitis or pleuritis. And you can separate that out based on what you see under the microscope when you do your fluid analysis. I'm not going to spend a lot of time on Rivalta's test. We always put it in there because it's like the test, you'd put the drop in the vinegar and the acetic acid and you see whether it falls. The truth is that although it should differentiate FIP from other causes based on the protein count, the positive predictive values and negative predictive values that are reported for that test were done in a laboratory setting where half the cats had FIP. And generally speaking, half of our cats don't necessarily have FIP when we are testing them. It can be useful for sure, but I feel like a lot of times if I've done my fluid analysis and I'm looking at my clinical impression and my signalment, that I don't necessarily need a Rivalta's test to do that. And it will actually come up positive for some of the differentials as well. So whether it's truly picking out that FIP from the others, I don't find it that practical for me. There may be people who love it, in which case, go for it. Whatever you love, do. Histopathology is the gold standard, so that does mean either exploratory surgery or necropsy. This is certainly problematic when it's older cats and we're doing it as an exploratory. We may not want to chase that, but sometimes that's where we may get a dry form diagnosis. You do need confirmation. Essentially what you're looking for is for coronavirus in macrophages, because again, what distinguishes that FIPV is that tropism for macrophages, that it has moved into the white cells. So that's what you're looking for on those stains in order to definitively say, yes, this is FIP. And basically, if you're doing necropsy or you're doing exploratory surgery, you may also see some of these classic lesions. So you've got the pyogranulomatous sort of depositions around various vessels. Liver is kind of classic. Kidneys are classic. Mesentery, if you kind of lay it out, you'll see all the little granulomas all along the blood vessels. Those are your classic lesions for sure. And again, then histopathology, you demonstrate the coronavirus in the macrophages and you feel like you've got a true diagnosis. But this comes from either an extensive exploratory or necropsy, which for those of us who are in shelters, getting to the necropsy part usually feels a little bit like a failure, although it's not. These are terminal cases, but honestly, we would prefer if there was something we could do on live cats, right? Isn't that what we all want? Is something we can do on live cats that gives us more answers, and that's where Dr. Whittaker is going to save us all, right, Dr. Whittaker? So there are some molecular testing updates. So IDEX does have a reverse transcriptase PCR for FIP. What it does is it looks for a mutation in the S gene. So it's looking for a specific mutation, and I'll remind you that in some cases we do think the mutations may be in different places, or at least we don't have evidence. That's the kind of thing people are still chasing. But this is looking for one of those mutations that has been implicated in FIPV development. It is most effective on effusions, and actually if you read the testing literature, that's what they recommend you use it on. So that means you actually have enough effusion in a cat to collect that effusion and send it in for testing. And again, usually if I have effusion, I feel like I can make a pretty good clinical diagnosis on the basis of my clinical signs and this fluid that I now analyze under a microscope. But if you want a confirmation, it can be good for that, to send that in and then they test that effusion. You can do it on tissue biopsies. Again, I feel like this applies more to private practice and kind of advanced private practice than necessarily shelters. You cannot run it on blood, not particularly useful because the viral load is often too low in the blood to actually confirm the FIPV. And you can't run it on poop, which is really what we all really want, is a test on poop. But it's not sensitive enough for that, so you can't run this particular test on poop. And they will speak to that. If you actually look at the interpretation of these, it'll come back positive for FIP if they identify that coronavirus has mutated and it has that S mutation, and they're running it on the effusions. They can also distinguish it from FECV, meaning that the feline coronavirus is not mutated, and so they're unlikely to have FIP. But it's important to recognize that cats can have both the FECV and the FIPV simultaneously. They can have both of those. And so that starts to confuse how they're reading the test and what your results are, which is why then we have an indeterminate where it can't be typed, and then below limit of detection, not enough virus, which just speaks again to why blood and feces don't necessarily work. So the challenges in the testing, again, are that they can have both, which makes it challenging, and that we're often seeking specific mutations, but that these mutations can be unique between different FIPVs, and so therefore we're constantly chasing new mutations to try and diagnose. And often you have low antigen, low levels, because the disease itself is the body reacting to the disease with their various immune responses, not the actual high numbers of virus necessarily that is circulating. So commercially speaking, that's kind of what we have out there. Dr. Whittaker here at Cornell has been chasing this virus for a while and is really focusing on some of the genetic sequencing specifically. And so this is on the clinical trials page of the Cornell Teaching Hospital, because they will often accept confirmed cases of FIP, and correct me if I'm wrong, but accept bodies of confirmed cases of FIP so that they can then do some sequencing on those to try and recognize where in the genome are the various mutations occurring. This doesn't necessarily help you with the management of your live case, right? Because this is on necropsy submission, but it can be a form of both confirming the case and contributing to the knowledge of what kind of mutations are out there. So I wanted to make sure you knew that that exists. And then there's a whole bunch of studies that are happening kind of simultaneously, because this is a really hot area to investigate. And so the big areas are understanding what the mutations are as a way of trying to decide what diagnostic points can we go after on live cats. That would be even better. And also kind of chasing treatments. What can we do once we have a treatment? And chasing prevention in terms of vaccination. So in terms of all of those things, there's various research projects. This is just from the WIN grants that occurred in the last year, in the last cycle, looking at genetic differences, looking at feline coronavirus in respiratory tissues, because I'll remind you, as I said earlier, coronavirus does replicate in the oropharynx, so is there something we can do there to both either investigate the presence of the virus or whether we might be able to predict anything from that. Working on an attenuated FIP vaccine, because the current vaccine is not recommended. And then also looking at combined anti-coronaviral therapy. There are several treatments that are under investigation. I'll go to the next slide, mostly because I've detailed it there. A cure certainly evades us. There is no cure. It is still a terminal disease. There are some palliative treatments that are out there, and all of these are somewhat experimental. Or entirely experimental. But the goal is kind of looking at suppressing the immune system response to the virus in any of these treatments. None of them have been curative. Several of them have been palliative. So in particular, the PIP, the polyprenyl immunostimulant, has shown that it can prolong survival of affected cats and reduce their clinical signs over time. The 3CL-Pro protease inhibitor also has shown that it will cause regression of some signs and slow progression. Again, I would argue that these treatments are really kind of reserved for more of a private practice owner scenario. I don't necessarily know that prolonging the process for an animal in a shelter seems like the most humane course, but they are out there and they're ongoing investigation, and who knows, maybe we'll find something that does seem reasonable in a shelter setting. I don't know anybody in a shelter who has been part of these clinical trials in particular, but I do know owners who it feels like it has given weeks to months for some of the cats at a decent quality of life. So what does this all mean for animal shelters? Well, again, reminder, we made this. Not we, not the people in the room, but essentially by deciding we loved cats and wanting to make lots of them in catteries, and by deciding we loved cats and we wanted to bring them into shelters and save them, even when it was an animal control mandate of the 1950s sort of animal control model. By bringing them in and densely housing them, we created environments where they shed coronavirus, and that large mutable virus wants to mutate, and so essentially we end up with a lot of coronavirus and then mutations of coronavirus. And so the popularity of cats that came up in the middle of the last century is part of why we saw this disease develop and then recognized in the 1950s. It was all part of that process. And so I think the take-home message there is that it also means we can think about how to minimize or how to try to decrease coronavirus in our environments and how to manage it in ways. So yes, cleaning all the things is important. We're not going to eradicate it by cleaning, but we certainly can minimize the load of the virus in our shelters. And so recognizing that it's endemic in cat populations, at least we want to minimize the enteric coronavirus that we're seeing in the environment. It can survive up to 7 weeks in the environment, but it does respond to most sanitation and cleaners and mechanical removal. And for me, the biggest take-home message in this is litter box management, because that's where most of it's being shed. And so using disposable litter boxes for animals with diarrhea is one of the first recommendations that I make when a shelter calls me and says we have a really high rate of coronavirus, or we have a really high rate of FIP. I talk to them about litter box management first, because that's easy. In my list of controls for what I can change, let's look at disposables for our most susceptible animals and any cats with diarrhea. Let's make sure the feces are being cleaned up in a timely fashion, because they can recontaminate themselves with higher levels and contaminate each other. If you've got a really virulent strain, it may be something where you do need a clean break. So you feel like we're getting a lot of FIP, we may have a hot strain of coronavirus in our shelter, maybe we'll do some testing through one of the labs that I'll talk about in just a moment. You may need a clean break to actually kind of stop intake, clean some systems out, throw away the boxes that you have, get new boxes, and really kind of strategize on trying to control that. Other is to minimize exposure, and this means capacity for care, all the things we talk about in all those other shelter medicine lectures, making sure we're not overcrowding our shelters, making sure we're decreasing length of stay in any way possible, making sure that we're eliminating bottlenecks, making sure that we're using foster appropriately, all those elements that we don't overcrowd and we're sticking to what is a manageable and humane population. Fast tracking kittens and segregating by age. Reminding you that they are our highest risk for shedders and our highest risk for disease. Let's keep them in the shelter the shortest amount of time possible. Let's make sure we segregate them from other animals as much as possible. And let's make sure that we segregate them from each other, meaning as much as I love a room full of 25 kittens running around together, I don't really love it. The part of me that loves kittens is like, oh my God, I love that. It looks like Kitten Bowl. And then the other part of me is like, oh my God, that's a coronavirus FIP nightmare, right? Because they're all running around shedding their various coronaviruses, all mixing together and then all getting exposed. So I'm a big fan of kittens remain in litters. They don't go in rooms together, in communal rooms. They can be in rooms of cages together, but I don't like to see litters of kittens mixing together, because it does seem to elevate our FIP risk for sure. Incubating, the long incubation period of FIV makes quarantine unrealistic. So I've had shelters call and be like, should we just quarantine our coronavirus cats and like keep them on lockdown for a few months and test them? I'm like, nope, don't do that. Let's clean instead. Let's minimize overcrowding and stress. Let's manage comorbidities. So if they've got high parasite loads, you've got a high rate of upper respiratory, you've got all those other stressful events that are happening, let's try to mitigate those risks. Because we're not going to eliminate this disease. So we've got to figure out all the other management pieces. And again, communal housing, not for kittens. If kittens have diarrhea, they should be monitored. They should be isolated from the other cats and from healthy kittens in particular. And then also kind of managing the risk of fomite transmission and all of those things that we automatically do as part of our gig. Okay? So I did not go into a whole capacity for care sort of lecture, but all those pieces come into play for how we're going to deal with this in a densely housed kitten population. So FAQs. What's the status of the FIP vaccination? It's a modified live intranasal, reminding you that coronavirus is highly mutable. What we know about trying to vaccinate against highly mutable viruses is it's a real challenge, because what you may be vaccinating with them with doesn't actually protect against the mutation that you currently have. And so the commercially available FIP vaccination is not recommended in most situations, and not recommended as anything we use in shelters. The goal would be similar to kind of what we talk about with influenza vaccination, is to develop a vaccination that's actually more cross-protective among the various mutations, and we're not there yet, but that may be an area of future research. The question I get a lot is a kitten in our shelter developed FIP. This singleton was in with other singletons. What is the risk? So non-genetically related kittens that have been co-housed. And officially, the risk should not be higher if we're going with that classic genetic predisposition. However, is there a risk that this kitten could have picked up a hot version of coronavirus that's more mutable? Does it put it at higher risk? And it probably does. I do think that disclosure is really important. To kind of say this cat was exposed to coronavirus, it was exposed to another cat with FIP, the risk is minimal because it really is minimal. But I do think it's important that we actually kind of disclose the kitten's history. And when do we adopt them out? I don't see a lot of need to kind of hold on to this kitten necessarily, unless you're seeing clinical signs. And so my recommendation is always, we need to really monitor this kitten, do a good physical exam on it, get out the ophthalmoscope, look at the fundus, track the clinical history. Does it have any signs of FIP development? And if it doesn't, then I keep moving it through the system. And there's really no place for testing because we don't have a really good test for that at the moment that's commercially available. A kitten developed FIP, what do we do with the healthy sibling? So now we've got genetically related, identical, little pointy-eared Maine Coon varieties. They kind of look like they were cloned, which is even worse, right? Like those last two look like they're identical twins. They are at a higher risk. So epidemiological statistics support that they are 2 to 10 times more likely to develop FIP. They may have the genetic predisposition. They've been exposed to the same FECV potentially. And so what do we actually do about that? And again, I think this is one where we do have a need to kind of provide disclosure to adopters. I always put this in the context of life-saving because there's a good chance these kittens are going to go on and live perfectly normal, healthy lives. There's a higher risk that they could develop FIP. And so I've got templates for various conditions. And this is one where it's like this kitten was exposed, its sibling developed FIP. This is not considered a contagious disease. We have no indication that this was a contagious strain, that we have no outbreaks. Your commitment to adopting kittens is part of what allows us to save their lives. And some kind of, music playing in the background. Let's all feel good about this thing. I think a foster to adopt potential, if you're really worried, is another thing you can do. Again, people are going to fall in love with that kitten on day one, right? Especially the super pointy-eared one in the middle. They're going to fall in love with them right away. But at least you've kind of put it out there that we're concerned about this. Can you monitor? We'd love to see this kitten back in 2 weeks. We'd love to see it in 4 weeks, and then we can start to feel a little bit better because at least time has passed. The other kitten had developed it in that window. Can I guarantee it's not going to show up later? I really can't. But a lot of times, tell me if this is true, a lot of times I see these kind of like a domino effect with some of these litters where you get the one and then you get another one a couple weeks later and another one a couple weeks later. So I breathe better once I get out that window. There's no science to support that it's not coming down the line, some sort of dry form later. But that tends to be how it occurs, at least in the cases that I see. So foster to adopt may be something that provides you a little window of time to kind of really think about risk assessment and monitor that cat. Testing with the reverse transcriptase PCR, if you don't have effusions, is not going to necessarily help you. And that's essentially the best thing we've got commercially at the moment. But I do think this is kind of the window of where we look in terms of future test development. And luckily, we're going to have a couple of minutes to take some comments from Dr. Whittaker. So if you think you're having an outbreak of FIP, you've got greater than 1%, you're kind of having a rash of cases, you have unusual numbers of cases, you have adult cats that are developing it, like older adult cats developing forms, and you're like, this is kind of strange. Anything that you are seeing like that, sample collection is important, and we want to know. We want to help you. So our program has a consultation hotline. It literally rings through to a phone, which is in my purse right now. So the caveat to that, it's a pink iPhone. Which I would never own a pink phone. Brenda picked it, if Brenda's in the room. But do know that sometimes I can't answer it right away, like right now. I'm not answering that phone, but we do have a phone that rings through. We have an email, which is usually a better way to reach us, so sheltermedicine@cornell.edu. We have some pamphlets out front. So we have a consultation line. If you think you're having an outbreak of FIP, we want to hear from you. Do know that I'm going to ask you about 50 questions, so be prepared for that. But we want to help kind of explore what's actually going on. Are you truly having an outbreak? And then is there anything that we might be able to test for or help you? Again, commercial tests are fairly limited, but research labs are doing a lot in the area of investigation around this. And that's exactly how we're going to make any progress, is being able to feed into that research line. And one of the benefits of being at a place like Cornell is being able to help in terms of a research approach. Answers are slow, especially in something as complex as this, but the only way that we track them is to hear from people out there in the field and to be following these cases. So I'll stop talking for a minute, and I want to introduce Dr. Gary Whittaker, who's in the audience, who is obviously the Whittaker Lab and our FIP researcher and guru here. So do you want to say a few words and then maybe take some questions? You're welcome to come up.
Okay, so first of all, I'd like to thank Dr. Belinda for actually a fabulous sort of way to kind of get this very complex disease out there. It is a really very complex disease. I'm a infectious disease virologist, and it's really, I think it's more of a syndrome than a disease. I'm really thinking it's more like HIV/AIDS. We have to kind of completely rethink the way we approach this. So so I want to sort of put that out there. I'm happy to take some questions. I want to make two comments in terms of clarifications or going a little deeper into the basic side of things. Dr. Belinda mentioned two serotypes. That's clearly true. But the more we're finding out about the virus, the more it's really two very different viruses. It's not really, I think it's not the right thing to think about it as two serological variants of the same thing. They're two very different viruses. Certainly as the spike protein goes, the spike protein is the kind of the driver of pathogenesis. So it really is very different viruses. So keep that in mind. And what we know about one virus may not apply to what we know about the other. And I think there's possibly a lot of misconceptions out there because the type 2 virus grows very well in culture, and as basic scientists and virologists, we can study a lot about that virus. But the type 1 virus does not. So the clinically prevalent virus does not grow in cell culture, and I think it's a little dangerous to try and cross-populate information from one virus to another. So that's just to put that out there. We're going back to basics and really rethinking a lot of things. The other comment I would like to make in terms of the FECV, FIPV kind of diagnosis sort of breakdown, that's certainly true, but I think that's really the bookends. We need to think about that as two bookends of a spectrum. And we're in the process of trying to develop diagnostic tests and kind of rethink a lot of things. And I've taken a little leaf from actually cancer diagnosis in humans, where we have like grade 1, 2, and 3 as cancer. So we're actually taking that kind of concept right now. And FECV would be a grade 1 and FIPV would be a grade 3. But there's possibly and quite likely a lot of grade 2 viruses, which are really not really getting diagnosed. And there's quite a range of those grade 2 viruses. As we're developing the molecular testing, we can start to kind of tease some of this out. But there's possibly a lot of intermediates, these so-called systemic FCoVs that you may have heard about, are causing, we need to think about that a little more. And so ultimately we may end up with a grading system. It's taking a long time to figure that out because it's complicated, but we're hopefully making progress. And I think a lot of the testing is really coming down to the detail in primer design and chemistry of PCR reactions, because it's not so much that there's a low sensitivity or there's the very low virus, let's say in the blood, but it's possible there's a window of the virus comes into the blood and disappears. So the testing in the blood is erratic. It may not be a sensitivity specificity kind of thing, but it may be just the virus is progressing through the body, and we're trying to figure out what's going on and trying to match that with the testing. So I'll leave it at that, because I know we don't have a lot of time, and I want to leave some time for questions if people have them.
Linda? Shout.
I just have a question about prevalence. But I have a sense that a lot of our cases we never know about. They probably develop after they're adopted.
Exactly.
So it's really hard to know what we're dealing with.
Right. So the comment is about prevalence and not necessarily knowing, because we're not tracking long term. We don't know how many cases develop, and I absolutely agree with that. We don't know. We use that 1% to reflect kind of in-shelter occurrence. That's what we're talking about with the 1%. In terms of prevalence of disease in the long-term population, I don't feel like we have a good handle on that for exactly that reason. Good point.
and if I could comment in addition in terms of, I'm no epidemiologist by any means, but to me, it seems that if you don't have a good diagnostic test, it's very hard to figure out what the prevalence is, because there may be unrecognized cases out there that are important, and if we're not able to test for it, the serology is, there's lots of cats are positive by serology. To me, that doesn't really mean very much, but without the good molecular diagnostics, it's very hard to do epidemiological studies and figure that kind of thing out.
Can you talk a little bit about what you're doing with feces and blood? And
yeah, so
willing to share?
So we're in the process of collecting a lot of samples. I think we have close to 1,000 samples of cats with different forms of FIP in the lab right now. So we're working through this. It's obviously a big, slow process. We're collecting samples from FIP positive cats who have been euthanized, and we'll take bodies and do necropsies and do testing from there. We'll take samples from cats, from feces from cats, blood from cats. We're looking, sort of keeping a very open mind, looking for whatever samples we can, in a sense, get a hold of. We have a study with Dr. Berliner right now on looking a little more at the respiratory component. I think there's more kind of action in the respiratory tract than people realize. We've had situations where we've got FIP cats have come in, and we've done necropsy and opened up the head. And actually, I want to mention, Nicole, my technician, is out there. She's participating in the conference. Nicole, put your hand up so we can figure out where you are. She's right there in the back corner. So she's very tenacious, is Nicole, and she goes into these. She does the necropsies and really goes into the. We had a study, a neurological study. So she's looking at the opening up the heads of these cats and finding all kinds of things going on in the upper respiratory tract, in the sinuses and the cribriform plate. And there's a lot of action, if you like, going on in the upper respiratory tract, in combination with FIP, that maybe is a way of the virus getting into the brain in the first place for the dry FIPs, but also possibly in this sort of window of the stage 2 viruses. As I say, we're keeping a completely open mind in terms of transmission modes and really focusing actually for the next year or so on the respiratory component and how that factors into FIP, because I think it's really not been addressed very well in the past.
And so if you call us, I sound very different. I sound better. So if you call us and you're experiencing an outbreak and we ask you a bunch of questions, there's potential that we may ask you to collect some samples, feces, blood potentially, and all of that. The important thing to recognize there is that none of this is commercial at this point, and these poor people are essentially doing all of this by themselves in a laboratory here. And so a lot of times it's not going to be like when you submit commercial samples and you expect your results tomorrow and you want to know exactly what the interpretations are. And so my caveat is that it may not provide answers for you in that moment, but it may provide you some insight into what risk factors are at play or how risky this virus may be, the one that he finds in those samples. And it may also contribute to some of the research that's going on to try and answer some of these bigger questions. So I always make sure to add a caveat. This isn't like when you send something to the diagnostic lab or IDEX where you get a reading back the next day and boom, you act on that. Like sometimes it's much more complicated than that because we don't necessarily know how to interpret the results that we get. Is that a fair assessment?
Yeah, right. There's a lot of interpretation needed. And the testing is, and actually, if I have a little time, Dr. Berliner mentioned the IDEX test, which is a mutation in spike. We are also looking at mutations in spike, but I want to stress that it's a different part of spike. It's a big, complicated protein. So I can't really do a direct comparison because our PCR reaction is not, and we PCR and we sequence, but that's a different part of the spike to where the IDEX test is based. So we can't really comment on how those two tests line up. But the sequence, so we have to run through a sequence and reaction, and then it's really a case of interpreting the sequence and trying to fit that into really some really basic biochemistry. The virus goes through this process of activation. And we're trying to sort of, I'm trained as a biochemist, so that's kind of where I'm coming from. So it's really becomes like a biochemical interpretation of the genetic sequence that really translates into the function of the protein is the way to view it. So it's not easy to do that.
So we are out of time. Thank you very much for joining me up here. We'll be up here for a few minutes. You have additional questions. Enjoy the rest of the conference.